On May 17, 2022, a seemingly routine visit to a sexual health clinic in London turned into the first public flashpoint of a viral storm that would soon leap across continents, exposing the fragile seams of modern public health messaging. The patient, a man in his early 30s, presented with a painful rash that resembled an unfamiliar cousin of smallpox, and within days, the world would learn that a rare poxvirus, monkeypox, had quietly slipped out of its endemic African cradle and was now marching through the heart of the globalized cityscape. Monkeypox is not a novel pathogen. First identified in 1958 among laboratory macaques in Denmark, the virus belongs to the Orthopoxvirus genus, the same family that harbors the dreaded variola virus, the cause of smallpox. For decades, human cases were sporadic, confined mostly to Central and West African nations, where the virus circulates among rodents and, occasionally, non-human primates. The disease manifests after an incubation of 5 to 21 days with fever, lymphadenopathy, and a characteristic centrifugal rash that progresses from macules to pustules before crusting over. Historically, the case fatality rate hovered between 1 and 10%, varying with the viral clade and host factors. The 2022 outbreak shattered that geographic containment. By early June, clusters were reported not only in the United Kingdom but also in Portugal, Spain, and the United States. By the end of July, more than 16,000 laboratory-confirmed cases had been logged across 75 nations, an unprecedented spread for a virus previously considered a regional curiosity. What made this surge especially perplexing was its epidemiological signature. The majority of infections were among men who have sex with men, with transmission linked to intimate, often sexual contact, a route not traditionally emphasized for orthopoxviruses. This nuance sparked a cascade of public health dilemmas, as authorities struggled to balance accurate risk communication with the danger of stigmatizing a community already vulnerable to marginalization. Key facts emerged quickly as investigators raced to decode the outbreak's dynamics. Genomic sequencing revealed that the circulating strain belonged to the West African clade, historically less virulent than its Central African counterpart. Yet, the virus displayed a surprising capacity for sustained human-to-human transmission, a feature previously thought to be limited. The basic reproduction number, R0, in several European hotspots hovered around 1.5, enough to fuel exponential growth without the classic zoonotic spillover events. Clinical presentations diverged from textbook descriptions. Many patients reported solitary lesions on the genitalia, minimal fever, and a prodrome that could be mistaken for common sexually transmitted infections. This atypical picture contributed to delayed diagnosis, allowing silent chains of transmission to fester. In the midst of this unfolding crisis, the scientific community mobilized its therapeutic arsenal. The antiviral tecovirimat, originally approved for smallpox under the U.S. Animal Rule, entered compassionate use protocols for monkeypox patients. A multicenter open-label trial across Europe and North America enrolled over 300 participants, assessing safety, viral clearance, and symptom resolution. Preliminary data, released in October 2022, suggested a median time to lesion resolution of 4 days in the tecovirimat arm versus 9 days in the standard care cohort, with no serious adverse events attributed to the drug. Parallel investigations examined brincidofovir, another orthopoxvirus inhibitor, but its hepatic toxicity profile curtailed widespread adoption. Meanwhile, the historic smallpox vaccine, notably the newer replication-deficient modified Vaccinia Ankara (MVA-BN) platform, was deployed in a targeted ring vaccination strategy, offering up to 85% protection against infection when administered within 4 days of exposure. While clinicians grappled with therapeutics, pathologists pursued the microscopic story hidden beneath the skin lesions. Autopsy studies, though limited by the relatively low mortality, provided crucial insights into the virus's organotropism. In one landmark case series from a German university hospital, tissue samples from a fatal monkeypox patient revealed widespread viral DNA in the dermis, oral mucosa, and notably, the lymphoid tissue of the tonsils and mesenteric nodes. Electron microscopy captured the classic brick-shaped virions nestled within cytoplasmic viral factories, confirming active replication beyond the epidermis. Unexpectedly, low-level viral presence was detected in the pulmonary interstitium, raising questions about subclinical respiratory involvement. Immunohistochemistry highlighted a robust infiltrate of CD8 plus T cells and macrophages surrounding the lesions, underscoring the host's vigorous but sometimes misdirected immune response, which can drive the ulcerative necrosis observed in severe cases. The aftermath of the 2022 monkeypox wave rippled through health systems, policy circles, and the public conscience. By early 2023, the World Health Organization declared monkeypox a public health emergency of international concern, prompting a coordinated response that emphasized surveillance, equitable vaccine distribution, and culturally sensitive communication. Nations that had previously relied on stockpiles of smallpox vaccine for bioterrorism preparedness pivoted to allocate doses for at-risk populations, while the United States launched the Jynneos vaccine for all individuals aged 12 and older with potential exposure. Importantly, the episode exposed the perils of a one-size-fits-all messaging strategy. Early advisories that framed monkeypox as a disease of men who have sex with men inadvertently fueled misinformation and delayed testing among broader demographics. Subsequent campaigns adopted a more nuanced narrative, emphasizing that the virus spreads through close physical contact, regardless of sexual orientation, while providing clear guidance on symptom recognition and isolation protocols. Beyond the immediate public health response, the outbreak reshaped scientific priorities. Funding streams were redirected toward orthopoxvirus research, accelerating the development of next-generation antivirals and pan-pox vaccines capable of conferring durable immunity without the reactogenicity of older formulations. Global health agencies revisited the international health regulations, integrating lessons on the importance of rapid genomic sharing and community-engaged outreach. Subscribe to the Autopsy Files for more stories like this.